Hi, my name is Kate Sullivan, and I'm here representing the Medical Advisory Board of the Immune Deficiency Foundation. This video has answers to several common questions that patients living with primary immune deficiency might have about the ongoing COVID-19 pandemic. I'm going to answer 4 questions specifically, but I'm going to start with just a little bit of an update. The video from last week was accurate as of that time, but there are more data that are coming out now, and I do want to start by updating you. First of all, a word about nomenclature. People have been using COVID-19 interchangeably with the disease and the virus. This is a small point, but just so it's clear when people are talking on the news, COVID-19 reflects the disease, and SARS-CoV-2, which is quite a mouthful, is actually the name of the virus. The recent data that has come out is that most typically the disease has an incubation period of 4 to 5 days. The incubation period is the length of time from exposure until the person has symptoms. Most patients in China actually went very quickly from being asymptomatic to being sick enough to seek medical attention. Having said that, the newer data suggests that 80% of people have a very mild illness that's no different from the common cold. So who is at risk for more severe disease that causes shortness of breath and cough and would send someone to seek medical attention? The risk factors that are known so far really reflect around age. Over 60 is one risk bracket, and those over 80 represent a second risk bracket. Now, you have no doubt heard that many of the patients that showed up in China, which is where most of our information has come from so far, also had another medical condition. You will be relieved to know that only 2 of the 1,000 patients actually had a recognized immune deficiency. You will also be pleased to know that the medical community that serves patients with primary immune deficiency is rallying to try and learn more about what types of immune deficiencies are at risk, if indeed there is any additional risk related to having an immune deficiency. So back to the virus for a moment. So a 4 to 5 day incubation period on average. The longest reported incubation period to date is 12.5 days, and that is why it is a 14-day quarantine, because everyone feels confident that if someone was going to get sick, they would be sick within that 14 days. Now, COVID-19 and influenza have many features in common. They are both spread by respiratory droplets. They both cause infection of both the upper airway and the lower airway, meaning the lungs. Influenza has a much higher rate of gastrointestinal symptoms, so things like nausea, vomiting, diarrhea. So in the United States, about 1/3 to half in any given year of people with influenza will have gastrointestinal symptoms of some sort. That's much lower in COVID-19. Only a tiny minority had gastrointestinal symptoms. Finally, the majority of patients present with fever and cough. So 89% of the patients reported in the China outbreak had fever, and cough and shortness of breath were the other 2 common symptoms. Now, one thing of interest to our community is that most patients in China also had a low lymphocyte count, and I think that is something that we need to pay more attention to. Now, just to provide some context, COVID-19 in the United States so far, as of today, March 10th, has affected 400 people. In contrast, influenza already this year has affected millions of people in the United States, and there have already been probably 20,000 deaths from influenza. So I'm going to give you an update on COVID-19, but I think it's important to use some of the lessons to help protect all of us from all respiratory viruses, because that will serve us all well going forward. So what are the 4 questions I'm going to address? What is the testing for COVID-19? Who gets it, and what does it mean? I'm going to talk about lifelong immunity to COVID-19. risks to patients with immune deficiency, and whether immunoglobulin is protective. So let's take the first question. What is the testing that's being done? Why were the tests rationed? Why couldn't I get a test at my doctor's office? So, a couple of things to know about the test. The testing is PCR based. A PCR test measures the nucleic acid of the virus, the actual structure of the virus itself. It is not an antibody test, so there's no disadvantage to being immune deficient. It would be as detectable in an immune deficient patient as it is in anyone else. The testing is now pretty widely available at major medical centers. Last week the testing was being rationed just to those who had a fever and a cough. I'm going to go over the new test guidelines that were just released yesterday, but please know that the testing is pretty sensitive as far as we can tell. It's still very early days. And many of the tests are unique across the United States, so the testing is not exactly standardized. So importantly for our patients, what were the changes to the guidelines for testing as of yesterday? So last week when I reported to you, the testing was restricted to people with fever and cough who had symptoms that seemed like it might be COVID-19. As more tests have become available, that has been liberalized, but I do want to give you a caution. You should not just show up and ask for testing. It is not predictive, so it will not pick up if you've been exposed. It will only pick up if you are actually sick with it. So what are the new guidelines? The new guidelines suggest that testing can be applied to those with acute respiratory symptoms, 1, hospitalized patients, 2, patients at high risk, which they are now defining over 65 years of age, and anyone with a chronic health condition. And they also have a special call out for healthcare workers who have been exposed, and I'm not going to talk more about that. One of the major changes in the guidelines have been the inclusion of allowing people with subjective fever to be tested under the new guidelines, which was not the case last week. And I know that will come as a relief. But I do want to say again, this testing will not pick up if you've been exposed. If you have acute respiratory symptoms and feel that you may have been at risk because it's present in your community, you can discuss with your doctor whether testing is appropriate. But it will not predict whether you're going to come down with the illness because you shook someone's hand. It will only pick up the virus in your nasal secretions and your throat secretions if you are actually sick with it at that moment. So that's an important thing to remember. Question number 2, will I have lifelong immunity if I get COVID-19? So this depends on your particular immune deficiency. We think, as is true for most respiratory viruses, that lifelong immunity will be due to the generation of antibodies to the virus. If you have an immune deficiency where you do not make antibodies to the virus, then you are not likely to have full immunity. That does not mean you cannot have some immunity through some of your white cells remembering the virus. And that has been shown for influenza, but as of right now, we do not know how much protective immunity will be generated either by antibody or by T cells. At the beginning, I noted that in China, there were only 2 patients reported out of the 1,000 that they characterized who had an immune deficiency. So certainly immune deficiency is not a major risk for severe disease, but we simply don't know at this moment how much of a risk it is and how much it varies across different diagnoses. Perhaps people with antibody problems have the same severity of illness as everyone else, but perhaps patients with chronic granulomatous disease have more severe disease, or it could be vice versa. We simply do not know, but you will be pleased to know that there is an international survey where we are trying to gather this information to serve your needs. This has been a very common question over the last few weeks. I personally do not think it is likely to provide much protection. Remember, antibodies work by being very specific. So the antibody to this year's flu probably will not help you in next year's flu, and the antibody that was generated to last year's flu doesn't work for this year's flu. So antibodies are extraordinarily specific. Having said that, there are mild coronaviruses that circulate in the population every winter, and there are antibodies to the family of coronavirus. Could those provide some modest protection? I personally do not think so, but it has not been tested rigorously, and we do not know. So most immunologists are not giving extra doses of immunoglobulin because it doesn't seem like it's likely to work, and of course there are risks with extra doses. So I hope this information has been of help to you. I'm going to end with a link to a website that you may find useful. So we have heard from many people, and I've certainly heard from many doctors, that it is so hard to stop touching your face. And of course, that is one of the major routes of infection. So it can happen that someone coughs on you, and that's the reason for social distancing, staying 6 feet or more away. But to be honest, we mostly infect ourselves by shaking hands and rubbing our eyes, touching our face. It has been incredibly hard for everyone to learn how to stop touching our faces. I will include a link that has a couple of tips, and I'm going to tell you about a website that is run by Dr. Will Sawyer called Henry the Hand, which actually has a lovely video, really meant for kids, but it has a lovely video designed to talk to people about why it's important not to touch your face and how best to train yourself not to touch your face. And he sells these plastic shields called face shields that are designed to help train you not to touch your face. So I will leave you with a few links that I hope are useful to you.